Good afternoon, everybody. It's a great pleasure for me to be again here in Chile, especially also in Valdivia. And Matthias, Estefania, thank you very much for the invitation. Sorry that I cannot speak Spanish even. It's, I guess, 12th time I'm in Chile. And in the meantime, Chile is my second home, nearly. And also thanks Dalia and all the other friends I have here in your beautiful country. Okay, but I hope today, especially the young doctors, if you are going to internet, all this, a lot is written in English, so I hope you understand as well. Okay, my task is to speak about deformity analysis in lung bones. And this is very special. Perhaps with the other talks we have some overlapping in the planning. So first of all, I have a question to you. That means, what are your common causes for limb reconstruction surgery in your clinic, at home actually? Even you do not, as a young fellow or resident alone, but in the clinic. Are these more congenital or acquired? Can you raise the hand? Who is mostly dealing with congenital? Okay, there are only 5, 6, 7. And acquired, that means post-traumatic, are more. And that means, I would say, overall, 10% for congenital, 10 and 80% they have really actually no, they are not contact with deformities. So I hope in the future, if you have to do this, that you do it the correct way. So first of all, I guess, especially for you, I try to have my talk a little bit philosophical. That means, of course, there are a lot of textbooks. You can see all the values you need, and you can measure this, and there are a lot of electronic tools in the meantime, from Bone Ninja and all these tools. But this is only one aspect. The most important aspect for me is not the deformity itself, it's the patient. You know, we do not treat X-rays, we do not treat values, we treat a patient. So that means before we plan and perform a correction, should we think about the reason for the correction? Because not every patient needs a correction, even we are thinking it needs a correction. And we have seen the video from the airport. I very often look at people, and you see all deformities, and the people are walking normal. Huh? So, of course. Good. So therefore, we have some consideration. Why a correction is necessary? It is a biomechanical reason. This is our task, because the patient cannot recognize the biomechanical situation in the future. Or sometimes, today also, cosmetical considerations, that the patient is coming to you, oh, I'm not happy with my leg or my arm. Can you change, correct it? And you have to consider what is the aim of the correction. Restoration of the mechanical axis, restoration of the length, cosmetic improvement. And the other question you have to ask is, what is the etiology or the reason for correction? Again, acquired or congenital in childhood. And when should the correction be made? The point, the timing, and which technique at the end, acute or gradual, and we have some tellers, some workshops later on this, is the best for this patient. Not every. So what is the reason here? You see here such a typical example. It looks not very clear, good. Only one foot has an external rotation, the other foot looks good. That is something strange. And when you look on the X-ray, you see a healed fracture. So this girl, now 15 years old, when she was 10, she had a long spiral fracture of the tibia, and she was casted in a long leg cast, but without flexed knee. So they produced the rotational deformity. Of course, when this child is coming to me and asks me for a correction, I agree that it looks ugly, you know. But if it's bilateral, like Charlie Chaplin, nobody said, okay, we have to correct Charlie Chaplin because he's bilateral. So therefore, is the reason different? Then we have to think about the type of deformity. So we have the varus, valgus, anti-recurvation, rotation, shortening, lengthening. Very often in children, there is a combination of all and not only a singular, and this makes the planning different. And exactly in children, the deformity is very special. Because most of the deformity arises from injuries of the physis or growth plate, might continue, and the growth goes on, we have a fourth dimension. This means the length. Okay, we have to consider also this. And we have to think and discuss with the parents of the patient what are the long-term consequences. And this is the most important point of the deformity. And I try to do this in 2 points. The following 2 clinical situations are difficult to explain, which could manifest in the future. That means, how does the patient manage the deformity? We don't know exactly, and which objective consequence arise on the adjacent joints. So we have to explain this to the parents, and not every joint has the same, for every joint is the same consequence. So what can be indication for corrective osteotomy? There is a patient factor. It is an indication patient-driven. That means the patient is coming to you and is asking, look, I have this problem, I have pain, or cosmetically, you have to discuss, so it's patient-driven. But on the other hand, and this is your task, the biomedical factors, because we are the specialists, and what we are doing over these days, we learn how to analyze the deformity and to measure, and this we have to explain to the parents. That means the indication comes from the surgeon, from the specialist, when the patient does not know the future consequence of his or her deformity, perhaps as pain and arthrosis and so on. So when you have this, then you have to start to think about the planning. And planning is essential. Why should the plan preoperatively? Because it is the right things to do. Prevents mistakes. As you can see here, did they have a plan? You see there's something goes wrong in this, with this LA. Okay, timing of the correction. And here again, we have a special situation. Depends on the problems and the etiology. You see here in the congenital box, there are a lot of lines. That means a child can have at birth similar lengths and then goes different, or at the birth are different lengths, but over the time it adapts, and. So we have a lot of variations, and therefore the planning and the determination of timing is much more difficult than in this situation, you know. Up to the trauma, perhaps both legs were similar, the same axis, the same lengths, but then the trauma and something goes wrong, and then we have the deformity. You should not operate, and this is a statement, you should not operate on a living person without first developing a surgical plan. Preoperative planning is essential for circle frames, especially as preoperative planning for internal fixation. Here you see such an example of an unplanned application of a ring fixators. So that means if you are not going to take the time to do it right, send it to somebody who will do it, you know. Why make a flight plan before operating? You know, every pilot make the flight plan. They said, visualize your destination, your goal. What is the goal for the correction? See how to get there, highlight the route and each of its steps. Avoid wrong turns. That means repeated corrections. Anticipate preference in advance. So when you make a good preoperative plan, you can save time and less stress while operating. Planning, think was done before the case, and fewer accidents as complications and better outcomes. So now, when we have considered all this, we can go to the patient and the X-ray, and then we have to identify where is the deformity. So when we are looking this is not a child's picture, but anyway, where is the deformity? This is sometimes very difficult to say where is the clear deformity, and I hope after this seminar here or this course here, you will be able to do this. Normally, we are using our eyes, okay? We can say is something straight or not, but our eyes is very good if to to see, yes, this is straight and this is angulated, but how much it is angulated, we cannot say. Okay, therefore, the eye can differentiate between straight or not straight, but not about the values. So therefore, we need measurements. So I came now to these planning tools and to give some pearls and technical tips for deformity planning. And if this guru is coming on the slide, this is always for me an important slide, okay? So, first of all, we have to know what is the normal limb alignment. A line connecting the center of the joint, ankle joint, and this gives then, for the lower extremity, in the upper extremity is different, the mechanical axis. And this is where the weight goes through the bone. Okay, so you have to know some special points. And one of the special points, and this is the critical point, is the knee. And normally we say the center of the mechanical axis has to go to the center of the knee. That is not completely correct. We have some range. And especially here, you see, we can have a range that the axis goes up to 8 millimeters more medial. Not always. That means if we are in this range, this is still normal. What is also important to see, the mechanical axis deviation. This is the best word. I said, okay, what is the deviation of the mechanical axis and how much it is? And we have to restore this. So then you can have a medial mat or medial axis deviation, then you go to a varus. This is a varus situation. If the line goes in medial, this is a varus. Of course, this is a okay, or the vice versa is the lateral, that when we have the valgus in this situation. And this is the, and you see, always we are going from the center of the knee, okay? So, mechanical axis deviation is sensitive to deformities around the knee especially. I see here the guru is coming, the distal femur and the proximal tibia. Because you know, the knee joint is in principle a monoplanar joint, and therefore the alignment in this joint is very, very crucial. Deformities around the proximal end of the femur and the distal end of the tibia do not influence so much, especially the hip joint. You know, the hip joint is a ball and socket joint and allows a free motion. Therefore, it's not so important. Coming back, you see here the different lines we can show, make here in the center line, and then we can analyze, okay, it's a medial or lateral deviation, or is varus or valgus. Okay, this is the frontal view, and in the frontal view, again, you can differentiate mechanical axis on the femur and the tibia, but overall, this must be in one line. As you know, the femur has some variation to other bones, so therefore we have a different axis, and they have the anatomical axis as well. And how you can define the anatomical axis? If you make 3 points here in this, and then it's the middle line. This is the best technique, because sometimes you can have pathology here, and you can have pathology here, and then it's very difficult to find the anatomical axis. So, when you compare now the mechanical axis and the anatomical axis, you see they are different. And there is a range. This angulation between anatomical and mechanical axis is more or less 7 or up to 9 or 5 degrees. So this is the range of these two angulations. This is very important to know when you go for planning, okay? And even also here, the anatomical axis goes not through the same point as the mechanical axis, because anatomy means not mechanical axis. So you must not be astonished if this is in this way. Okay? Good. In the tibia, mechanical axis and anatomical axis are in one line. This is important to know. Joint lines. We have to see the joint lines, especially for the knee. The hip and the ankle, as I mentioned before, is not so important. Okay, so therefore it's important to look at the knee. In the knee, we can take these points, as you can see here, and then we make our joint lines. And these joint lines must be parallel, in principle. And as well, parallel for the lower leg, for the tibia, to the ankle joint as well. This is something special, not for the femur. Okay, so you see these are the two lines for the mechanical axis. So then we see here and here we have some angles. So we have to know these angles as well. And for this, especially draw Paley-Bate is all good work to show us all these different angles with the variation between mechanical axis and the anatomical axis and so on. Therefore, I will not go in details. There are the textbooks, but you have to know how to do this and what means the mechanical axis. But sometimes you can fail, you know, because, especially not in kids, but even also in kids, you can see this sometimes, because of the laxity in the knee joint. That means, is this a real valgus or a varus or not? No, this is not a real varus. If you analyze the axis, then you see you have more or less the correct angle, but you have instability in the knee. So you have to take care on this. So in summary, what are the most important values you have to know? That are this value here, the medial and the lateral angle and the medial angle for the proximal tibia and the distal femur, and here the lateral angle for the distal tibial. These are the three most important angles you need if you go for anatomical planning. But don't forget the sagittal plane. You know, in the sagittal plane we have also some landmarks, and also here, this in green, these three angles are the most important angles that you have to know. Here again, a little bit bigger, you see this and this angle. I will not go in detail, this is all in textbooks. So, coming back to the patient. Patient first, as I mentioned before deformity, you have to look to the deformity. That means patient first, deformity next. That means you have to know the history, the functional versus cosmetic situation, as I mentioned before. So, now you came to the clinical assessment, first X-ray, and you have to make the analysis. Coming back to this, I showed this before. That means to measure the angle, we need X-ray. So the next step is to have good radiological assessment. Long leg coronal view of both lower limbs, standardized and that you can reproduce it. This is important. I will show you later on how important it is. Rotation takes into consideration with the patella. Don't forget the patella, facing forward. You will see this later. Long leg sagittal view of two limbs separately. So that is the worldwide accepted arrangement for X-rays, that you do this in this way, but you know, this is never orthogonal in this way or in this way. So that's a little bit problematic. You have to orientate the patella anterior, and this gives you the best view. Okay? So nowadays, with the digital films, you can compensate this, that you make different pictures, and at the end, the computer makes these different pictures to one picture. So then you see the most of the joint orthogonal. And don't forget, if you have leg discrepancy, that you compensate this as well. So then you have a quite good X-ray. You have a good quality here and a good quality here. This is the way. But nowadays we have, again, a new equipment. This is the LODOX or the EOS. Computer tomography is also possible, but the EOS today is the modern. And in the EOS or LODOX, you get such pictures for planning, you see in this way or in this way, and the radiation for the patient is very low. This in contrast to this. This has a very high radiation dose, and this has nearly no. That means such a total body X-ray has 10% of a normal thorax X-ray. Here, what is important in the planning, in the EOS system today, we can make standing X-rays, AP and lateral. You see, this is very important for planning. Rotational assessment is another point. Mostly in my hand, I do this clinically, but of course you can do this also by CT scan, but then you need the CT scan. Here is such an example. This is a post-traumatic situation. The patient had a bad gait, and you see in the CT scan, the surgeon produced a rotational failure, not a fracture. The surgeon made the failure because he did not recognize the rotation. Here I come to the point of the radiological follow-up. You know, this is a situation, and this gives you then in the planning also failures. You send the patient to the X-ray department, and every time the patient is positioned in a different way, okay? So, and therefore you get different X-rays and different angulations, and then you believe, especially in the continuous correction, you measured every time other angles. So you see here in the circle frame, here you see the master tab here. In the next X-ray control, it was here, then it was here, and then again here. So that means always in a different rotation. How you can avoid this? There is a simple trick. If you apply such a stick or something on the frame, and the patient himself can control. You know, the control of the patient is that, okay, this is parallel to the table. Here the patient sees, no, this is not parallel. So when the patient controls this, then you get always the same picture. As you can see here, you see all these pictures have always the same rotation. Okay, so you measure the correct way. Again, coming back to not to EOS, so to the traditional X-ray, the best way is to do this in this way, with the center line to the knee, and as I mentioned, also in a lateral position, you can do this in this way. You have to make this. And again, lateral analysis is also very important. Patella forward, you know, otherwise you can create a malalignment, which is not the true malalignment, as you can see here. So that means patella forward, and then you see the deformity is really real. Okay, then of course we have types of deformity: uniapical, simple, monoplanar, and with different components. And Matthias Sepulveda will speak about this as well, so I go not in detail, I show only how you measure this. The deformity analysis, that means measurement, mechanical axis deviation, make out the joint lines, hip, knee, and ankle, draw mechanical axis of femur and tibia, measure joint angles, identify deformed segments, and manual analog X-rays or rulers, what difference in contrast to digital methods we have today. Thank you very much.